the Orthopaedic Research and Education Foundation. And we're going to talk a little bit about congenital talipes equinovarus, the etiology and early management, mainly the Ponseti technique. And I have to acknowledge some of the pathology slides which were given by Dr. Bhadani for the use of teaching to all the pediatric surgeons of India. Like William Hazlitt said, that when a thing ceases to be a subject of controversy, it ceases to be a subject of interest. And the fact that there is still so much interest in the management of clubfoot suggests that there's still some controversy about its management. This painting by Jose Ribera lies in the Louvre, which is one of the largest museums in the world in Paris. Interestingly, this is actually not a true clubfoot, but a hemiplegic, if you see the position of the hands as well. Bradford, many years ago, more than 100 years ago, said that the literature in clubfoot is, as a general rule, that of unvarying success. It is often as brilliant as an advertising sheet, and yet in practice, there's no lack of half-cured or relapsed cases, sufficient evidence that methods of cure are not universally understood. I think this was true till fairly recently. I think hopefully with the Ponseti technique really making a difference, we don't see as many. Of course, we'll still see some of the neglected and partially treated cases or cases that have not done well, but by and large, I think the number of these recurrent and relapsed cases should reduce over a period of time. We all know the incidence of talipes equinovarus is between 1 to 2 per 1,000 live births. Interestingly, it is increased. There's an increased incidence in the Maori, the Polynesians, and African blacks and Hawaiians, while it's less common in the Orientals. It has a slight preponderance for males, almost 2 to 3:1, and the unilateral and bilateral cases are roughly equal. The actual etiology remains controversial. There are various theories which have been put forward, discarded, and then presented again by succeeding investigators. Confusion is often due to grouping together all similar deformities. So you get maybe a syndromic clubfoot, etc., being combined with the idiopathic clubfoot variety, which we are mainly going to talk about. So we need to differentiate the idiopathic clubfoot from local manifestations of systemic skeletal syndromes such as neuromuscular disorders, arthrogryposis, other bone and joint dysplasias and anomalies. Now, there are various theories which have been put forward for the etiology of clubfoot, and they start with mechanical factors in utero. There are neuromuscular defects which have been blamed. It could be a primary germplasm defect which has been suggested. Could be an arrest in the embryonal growth. So this could cause the defect because there's a phase, as we'll come, where the clubfoot tends to be in the position of the clubfoot, and any arrest in the growth at that stage might lead it to remain in that position. Hereditary factors have been also suggested, and a combination of heredity and environmental factors have also been suggested as causes for the clubfoot. Now, starting with mechanical factors in utero, this was postulated as far back as in the time of Hippocrates in 300 BC, but even more recently suggested by Dennis Brown in 1936, and still thought to be one of the factors responsible, as suggested by Wynne Davis in 1964. However, most factors causing raised intrauterine pressure occur later in pregnancy or in the latter part of pregnancy, and therefore there is no clear sort of correlation. And also there's no increase of incidence in clubfoot seen in twins or large babies or where there is a history of hydramnios. Okay, next we come to neuromuscular defects. This was suggested by Isaacs et al. who suggested that it's a primary neurogenic disease. And similarly, others have put forward similar theories as Handelsman and Badalamenti felt it was a neuromuscular abnormality. Bill and Worsfeld were unable to detect any neurological lesion. Okay? Lickplow, Mao, and Tonis felt it was a primary muscle imbalance that was responsible. Similarly, other people have suggested various things, including weakness of peroneal muscles and dorsiflexors. Again, other investigators have found no evidence of low motor neuron lesions. Ionesco reported fibrosis of calf muscles, and others who suggested there's no abnormality in the histology of the muscles. So I think there is a lot of different interpretations of the findings that you would relate to the etiology of the clubfoot. So again, Zinni et al. Observed 3 types of cells in the fascia of the medial side of the clubfoot. They found typical fibroblasts, they found cells resembling myofibroblasts, and they found mast cells. So this could be one of the reasons that that the myofibroblasts-like cells, which are there in the spring ligament of club feet or in the medial side, may be responsible for the deformity taking place. Irani and Sherman felt it was a primary germplasm defect because they found that the most conspicuous and only constant abnormality found was in the anterior part of the talus. Weisbrod in 1973 suggested a blastemal defect of the tarsal cartilaginous enlarge. Arrested fetal development has also been suggested by various authors, including Jutta and von Folkman. This has been supported by Bohm, but also been opposed by various authors, such as Wessel Hagen and Mao. Excuse me. Victoria Diaz in 1973 wrote about the growth spurts in development of the embryonic feet. Talked about a first stage where there was a fibular phase and a second stage where a tibial phase. So if during the fibular phase, there's a fibular overgrowth which tends to bring the foot into varus. And if the growth is arrested at this stage, it could lead to the curved foot. Holland in 1991 suggested defects in signals that provide positional information as a cause for the clubfoot deformity. Arrested fetal development could be due to extra uterine environment. There could be possible role of teratogenic agents, and Duraisamy in his experiments was able to develop a clubfoot-like deformity by injecting insulin into the chick embryo. Drachman and Colombo talked about the possibility of D-tubocurarine being involved. Arrested fetal development also has been shown in case reports by Diego, Shaw, and Steinbeck. And Turco found an increased incidence in the home for unwed mothers, suggesting that there could be some intrauterine growth defect or fetal developmental arrest, which could be the cause of this clubfoot. Wynne Davis, Kite, and others have shown increased incidence of clubfoot among relations of affected children, and they have suggested various modes of inheritance, which may be linked to the transmission of the clubfoot defect. However, there is no recognizable pattern of inheritance to suggest a clear-cut link between this. Heidelberger showed that 33% of identical twins would have the deformity if one had the deformity, while it was only 3% if the twins were dizygotic. So postulated that there was a polygenic multifactorial trait for the development of clubfoot. Rabeck et al. Favored the hypothesis that the deformity can be explained by segregation of a single Mendelian gene and other minor genes or non-genetic contributors. So used complex segregation analysis to sort of reach his hypothesis. And probably what most investigators believe, that is a condition that has a combined hereditary and environmental effect resulting in the clubfoot. So this is multifactorial, and this has been supported by various authors, including Palmer, Wynne Davis, and Turco. Okay, so that's where you come around to the idiopathology. Now, when it comes to the treatment, there's been, we'll talk a little bit more about the pathology as suggested by Kite, by Ponseti. But if you look at the treatment history, there's been a full circle that has taken place from Kite to Ponseti, where in the 50s and 60s, Kite was the most dominant figure in clubfoot treatment, where he suggested conservative treatment with casting. But then gradually, because of the failures of conservative treatment, people went on to soft tissue releases, to earlier soft tissue releases, to neonatal surgery, and more radical releases, till you started seeing some of the complications of this. So gradually, people went back to less extensive surgery, the so-called a la carte surgery. And then finally, with Ponseti showing his results with conservative treatment, the pendulum really swung quite decisively in favor of conservative treatment. So Ponseti did most of his work as the professor in the Department of Orthopedic Surgery, University of Iowa, where he eventually became professor and then professor emeritus. Now, to understand the Ponseti technique, you have to understand what the various deformities that you have in the clubfoot, or what he means by the various deformities. So he's defined each of these very clearly. So adduction is that movement of a tarsal bone which brings the distal part of the bone towards the median body plane. And abduction is the movement in the opposite direction. Similarly, flexion is that movement of the tarsal bone in which the distal part of that bone moves in a plantar direction. And similarly, extension is the movement in the opposite direction. Inversion is the movement of a tarsal bone where the undersurface of the bone moves towards the median plane. So you can just imagine what it means. The undersurface of the bone moves towards the median plane, and eversion is the opposite. So just the opposite would be eversion. Supination is a combined movement of adduction, flexion, and inversion. Pronation is a movement of abduction, extension, and eversion. Okay, so this is how you get pronation also. Heel varus is inversion and adduction of the calcaneum. Heel valgus is eversion and abduction of the calcaneum. Forefoot supination is inversion and adduction of the forefoot. Forefoot pronation is eversion and abduction of the forefoot. Okay. Similarly, equinus refers to an increased degree of plantar flexion of the foot, and cavus refers to an increased height in the vault of the foot. Okay. So now, just a little brief history about Ponseti is that he arrived in the University of Iowa Medical School to complete his orthopedic training. Okay, so at that time, different methods were being used by different members of the staff, which included the great Dr. Arthur Steindler, who you might have heard about the Steindler release. Okay, and Brockman release, which was a fairly radical release, was the release that was commonly performed for the treatment of clubfoot. What Ponseti found that most often this surgery left deep scarring, joint stiffness, and weakness of the feet. He looked back into the treatment and studied the treatment by various authors, and he found that Kite, who championed conservative treatment, tended to correct each component of the deformity separately, and the heel varus correction therefore took inordinately long. What Kite did not realize is the calcaneum must be abducted before it can be everted. So in 1923, Robert Jones had written that he had never met a case where the treatment had been started in the first week, where the deformity could not be completely rectified by manipulation and retention in 2 months. So this struck Ponseti, but when he looked at this, at the treatment by various people, the sort of result could not be repeated by anyone else. Partly this was due to the poor understanding of the functional anatomy of the normal foot and that of the club foot. Also, most people started treatment a bit later, 3 weeks or 6 weeks later, rather than within the first week of life. So Ponseti really studied the club foot very carefully. He studied range of movement of tarsal joints of normal feet and club feet under cine radiography. He obtained serial cross sections of children who were stillborn with clubfoot deformity and with normal feet, and trained his fingers to palpate the joints both in the normal feet and in the clubfoot. Okay, so gradually with a period of time, he's refined a uniform method of treatment, which he started in 1949. Okay, and then studied the results of it in 1948, and whatever patients he had treated between 1948 and 1963, he actually reviewed the results in an article in the JBJS, and he was convinced that he had the answer. However, relapses were frequent. So I think in the initial period, they were not doing tenotomies as regularly as they were doing it later. Okay, finally, when they started doing more tenotomies, and another part of the treatment was if patients had a dynamic varus, they would do a tibialis anterior transfer at the age of around 4 to 5 years. Okay, with this method of treatment, Cooper and Dietz actually looked at patients in a ophthalmology clinic, regular patients who had no clubfoot deformity, and then actually compared the results of their feet with those of treated clubfoot with the Ponseti method. And they found that actually the number of excellent and good feet were very similar in patients who had no deformity as well as those feet treated by clubfoot. So that was really the final clinching thing of Ponseti's treatment. Before that, he had come out with a couple of papers looking at the results, showing good results in 80% of the cases. But that was something which was shown in different studies by different people, even with operative treatment. So the fact that his treatment led to feet that were almost normal when you compared them to a normal population as far as the feet were concerned really made an impact, and then more and more people started using the Ponseti method. So in Ponseti's treatment principles, all components of the clubfoot deformity get corrected simultaneously, with the exception of the equinus, which should be corrected last. He showed that cavus resulted from pronation of the forefoot in relation to the hindfoot. Okay, so this is an important concept. And therefore, the first stage of the cast is supinating the forefoot. And this is done by elevating the first metatarsal head. And this supinates the forefoot and brings it in line with the hindfoot. Okay, so that is the first and most important step. Now, while the whole foot is held in supination, in flexion, it can be gently abducted under the talus. So the talar head becomes the fulcrum, and gradually against it, the entire forefoot is abducted by applying counter pressure on the head of the talus. Okay. Now, as you correct it and abduct the foot, the heel varus and foot supination will correct when the entire foot is fully abducted in maximal external rotation under the talus. Okay, you don't deliberately try to evert the foot. Okay. And finally, the equinus is corrected by dorsiflexing the foot. The tendo Achilles may need to be subcutaneously sectioned to facilitate this correction. And Ponseti did this as an OPD procedure. It was a complete tenotomy, not a lengthening or a fractional lengthening. It was a complete tenotomy that he did. And this was really based on his observation that patients who had their TA cut, this was during the concentration camps, they were soon able to function almost normally. So he felt in a child, even if you section the TA completely, it should heal back again. Okay, so the components of the deformity that he described were cavus, forefoot adduction, hindfoot varus, and equinus. Okay, and these are the pictures, and these are the slides from Dr. Pirani showing the various deformities. You can see the cavus quite clearly here. You can see the adduction here. You can see the varus of the foot and the equinus at the heel. Okay, so these are the components of the deformity. Okay, this is when you do the dissected section showing you the deformity, and the skeletal sort of model showing you the same deformity. So you can see how the talar head gets subluxed laterally. You can see that here as well. And you can feel that when you palpate the clubfoot that the talar head is sitting outside, and you need to bring this entire forefoot in line with the talar head. Okay, so this is the sort of picture of the pathological anatomy. You have varus, that is adduction and inverted calcaneum, the adduction with medial displacement of the navicular and cuboid on the talar head, the distal calcaneal surface is adducted, and the medial talar neck is the medial talar inclination, okay, neck inclination. Okay, similarly, the first metatarsal is plantar flexed, and that is the relative deformity that you need to correct. And there's also severe tibiotalar plantar flexion. Okay, so when you're correcting the clubfoot, what you do is, the first is to elevate the first metatarsal, which will correct the cavus. You abduct the midfoot, which will correct the adductus. You evert the calcaneus. That means as you're abducting the forefoot, the calcaneus should be allowed to evert, so don't hold on to the calcaneus, and that will correct the varus. And finally, dorsiflexion of the talus will correct the equinus, and this may have to be helped by a TA tenotomy. So the stages of the Ponseti technique in the manipulation and casting is first correcting the cavus, then the forefoot adduction and heel varus, and finally the equinus by a tenotomy, and this should be followed by bracing. Okay, so cavus elevation of first metatarsal, adductus abduction of the midfoot, varus by of the calcaneum, and equinus by dorsiflexion of the talus. So again, here a model showing how when you elevate the head of the first metatarsal, you get correction of the cavus of the foot. Okay. Similarly, that is showing the correction of the cavus by elevating the head of the first metatarsal. And this is in a patient, you can see how when you hold the foot in the position that it is in, you see the cavus there. As you're pronating the foot, it actually becomes more magnified. And then as you elevate the head of the first metatarsal and supinate the forefoot, you can see how the cavus has now disappeared. Okay, so this is very clear. So you don't have to usually do things like a plantar fasciectomy or fasciotomy to correct the cavus. The step 2 is forefoot correction of the forefoot adduction and heel varus. Okay, so this is done by abducting the forefoot or the forefoot and midfoot with the thumb on the lateral part of the talar head. Okay, so this is the fulcrum, and you move this laterally. Okay, so this is, as you do this out, the heel will also evert. You will correct the abductor. So here you can see how the thumb is at the head of the talus here, and you are keeping the head of the first metatarsal elevated, and you are abducting the forefoot with the talar head as the fulcrum. Okay. So this is the position of the hands. You need to keep the heel free and gradually abduct it and allow the talus to also, the calcaneum to also evert. Okay, again, an example showing how this is done from both the sides. Okay, now if you look at a model again, you can see the varus in the heel. And as you can see, as you abduct the forefoot, you can see how the heel is everting. So the calcaneum is everting as you abduct the forefoot. So this is basically the main basis in which Ponseti based his correction. And a lot of the work that he did to come to this was to come to these conclusions about how the foot should be manipulated. Okay, this is the cine radiography showing where the thumb is when you're putting the abducting the forefoot. Now the casts also varying from the first to the fourth or fifth or sometimes sixth cast just shows serially how the foot is being corrected. The forefoot is being brought into abduction over a period of time. And you can see also the heel correcting along with it. And that is the shape of the cast, the serial cast one after the other as you're correcting the club. Okay. Remember, the final part of the sort of treatment is the tenotomy, which allows the foot to, the ankle or the foot to dorsiflex. This is, as I mentioned, a complete section of the tenotomy, not lengthening. Just divide it percutaneously. You have to make sure that the tendon is completely cut. You can actually feel a snap as the foot comes into correction, or the equinus gets corrected and the foot comes into dorsiflexion. You should aim for about 15 to 20 degrees of dorsiflexion. Okay. This is a case where there was a recurrence, but you can see how nicely the TA has reformed after the tenotomy. Okay, there will be some minimal fibrosis in the region, but the TA forms back completely and is almost the normal strength. And this has been shown by Ponseti in the things like hopping distance and etc., the strength of the TA, etc., in the treated club patients. So how the Ponseti technique differed from the kite technique was that the kite technique, the correction of each component of the clubfoot deformity was separate and in order, while Ponseti believed that the correction of all the components should take place simultaneously. He cautioned against exacerbating the cavus by pronating the foot. Okay, so this is what again we talked about, is that must keep the first metatarsal head elevated to prevent pronation of the foot, which is the natural thing that you think, because you feel the foot is supinated, you may tend to pronate. Okay, now what Ponseti has again shown in his methodology is that the contracted soft tissue yields to stretching. Okay, and then once you stretch it, you need to give it some rest in a cast, and then after a few days, then do the next stretching. So this will help it stretch further. Okay, if you do it daily, then you might cause an inflammatory response which gets exacerbated, and that's why he felt that you should wait for 5 days, 6 days, or 7 days before you do the serial casting, as opposed to the manipulation that the French technique, and we'll talk about that in a minute. So this is the foot abduction brace. Now, when you finish your treatment, rather than use splints, keeping the foot in dorsiflexion, this is the method that has been suggested as the best method to maintain the correction. Of course, the foot has to be corrected first. Once you do your final cast, that cast is left on for 3 weeks. Okay, and then the cast is removed and the foot abduction brace should be put on the same day, okay, ideally. And for this, you have to have these available off the shelf in different sizes and use the size that fits the child best. Okay, so this is used for full time for 3 months. So you only take it off when you're bathing them or exercising them. After that, you use them at night time and nap times, okay, for another 2 to 4 years. Okay, the bar that's separating the 2 feet should be as wide as the shoulders, and the foot should be externally rotated to 70 degrees. That is the foot that is deformed. If a foot is normal, so if it's a unilateral case, the normal side would be at about 40 degrees. And you should try to make sure the foot is also, the heel is, the sole is dorsiflect about 10 to 15 degrees. There should be a heel cup and something to hold the heel there so that the child doesn't pull up the heel in the abduction brace, okay? And failure to wear the brace is really the most common cause of recurrence. Now, it's important that your brace has a low heel counter, okay? Because if this counter is too high, here's the low counter which allows the foot to move. If it's too high, as you sort of flex it, it is going to dig into the back and cause equinus of the foot. So it's better to have a low heel counter than a very high heel counter, which will cause equinus when you when it digs into the back of the tendoachilles. Okay. Now, as I mentioned earlier, this was the things which he showed experimentally as well, how the contracted ligaments stretch and the abnormal tarsal cartilages remodel. And this has been shown with MRI studies by Dr. Bhadani with the weekly cast. So every cast they've done MRIs of the feet in a number of cases to look for what happens to the cartilage. And they found that as you correct the foot, the cartilage and the bones can remodel to a better position. So as I mentioned, you must put the cast on the same day as you put the brace on the same day as you remove the cast. Okay, and then make sure it fits well. There's no sores or something developing, because that will lead to problems. And as soon as the foot abduction brace gets small, you need to replace it with a bigger size. So again, just going through the steps of the procedure so that it's reinforced is that the forefoot is corrected by supinating it and then shifting the navicular, cuboid, and calcaneus in relation to the talar head by abducting the forefoot along with the calcaneum. Okay, so that entire block gets moved together. The heel is not constrained, so that's why the calcaneum can move along with the forefoot. The fulcrum, as I mentioned, is the head of the talus and not the calcaneo-cuboid joint. So this was the difference between the kite and the Ponseti technique, where kite tended to press on the calcaneo-cuboid joint and try to correct the foot with the calcaneo-cuboid joint as the fulcrum. And the correction of equinus is frequently included a percutaneous tenotomy done under local anesthesia. And this is done in Ponseti's technique was done as a outpatient procedure. We still tend to do it in OT. We sometimes give them a very light anesthetic to do that. Okay, so this is just to put in the words of Tolstoy, that he said that I know that most men, including those at ease with the problems of the greatest complexity, can seldom accept even the simplest and most obvious truth if it is such as to oblige them to admit the falsity of conclusions which they have delighted in explaining to colleagues, which have been proudly taught to others and which they have woven thread by thread into the fabric of their lives. So this is typical of the clubfoot, where really from the 60s onwards, from Turco's time, most surgeons believed that conservative treatment didn't work and that you needed to do early surgery. And they started doing more and more radical surgery. And this led to problems much later on. So the feet may have looked all right at that stage, but as these children grew up, many of them tended to have stiff and painful feet. Okay. There is another method of manipulation for these early cases, and this is the French technique, which is known as the functional treatment, masse. And this is manipulative therapy with minimal of immobilization. So every day the child would go to the physiotherapist and they would do manipulations and then strap the foot. Okay, this would sometimes be supplemented by a rigid foot plate. Okay, and this has been reported by Ben Sahel with good results in 50, which increases to 86% with subsequent complementary surgery in a review of 338%. So you would do all this manipulation, strapping, continue that till you got a good correction. And if you had some elements of the deformity, you did as much surgery as was required. So you would do some releases to get the corrected foot, and this was reported by Ben Sahel. Okay. Serenge and Attia added active solicitation of peroneal muscle function, and this they showed a slightly better result, and still almost 50% needed surgery. So 50% did not need surgery, which meant that almost 50% needed surgery. And they also added CPM, that is continuous passive motion. Again, it's very difficult to do this in a small foot, but that's what they did. And with the addition of this, they felt that there was further improvement in the treatment. Okay, so this was another method, has not become very popular worldwide, but the French seem to think that this worked quite well. Okay, and they seem to show good results. However, it hasn't taken off as a method which everyone uses, unlike the Ponseti, where good results have been replicated by various authors. I'm not going to go through all the papers, but many authors have reported excellent results using the Ponseti technique, and all over the world. It's not just in one country or another country, but all over the world. Just a couple of examples, or one example for clubfoot treated with the Ponseti technique. Here's a follow-up and a 4-year follow-up showing an excellent result with good walking, and this is a 5-year follow-up from the whole time. So good functional correction with a mobile foot. Okay. Now, just to mention about tenotomy, I think if you want to avoid doing the tenotomy, you should be able to get the foot dorsiflex at least to about 15 to 20 degrees. This is a child we just casted today. This was the 5th cast, and we were able to get this foot up to sort of almost 20 degrees of dorsiflexion. So we decided in this child, we might be able to avoid a tenotomy. But this will, in our practice, forms only about 10% of the cases. 90% do get a tenotomy at the end of the casting. I'm not going to go now. We can even do the Ponseti technique in older children. I'm not going to go into examples of that. We've done them as late as 10, 12 years. It needs many more casts. Putting these older children in above knee casts can be difficult, but that is what you need to be able to get the full effect of the Ponseti technique. So take home would be that Ponseti technique has become a technique of the gold standard for treatment of initial treatment of clubfoot deformity. It leads to functional painless feet. There has been a great reduction in the number of soft tissue releases with the advent of the Ponseti technique. This should be started early as the 3rd, 4th, 5th day. As soon as the child is, you know that the child is okay and has not got any major disease or complication of or any neonatal complication, infection, sepsis, etc. We should be able to start treatment. And as I mentioned, we have also done these in very late cases, and this has also been written up by various authors where you can do this technique even in the later cases and get fairly good results. Thank you.
Thank you so much, sir.
Okay.
So
ready to
we have few questions in the chat box.
yeah, sure.
Dr. Amay Gursale wants to know about modified Pirani score and till what age the Pirani score is valid.
Okay, I didn't go to the Pirani score because that is something that all of you should be aware of. And the Pirani score is not a classification of the club foot. It's a guide to your correction of the foot. Okay. So when you do you have a midfoot score and a hindfoot score. Okay. And the maximum score is 6. And you should be down to at least 1 before you do the tenotomy. Okay. So that is the Pirani score. I think all of you should be aware of it and use it. So the score is used more as a guide to your treatment and not as a classification of the club.
So, sir, and that means that when all the deformity is corrected, only equinus part
Equinus
and
is left. That is when you should be doing the tenotomy, not before that. Okay. So usually if you start early, takes 4 or 5 casts. If they're later, then it takes more. And some of the late ones can take 10, 12, 15 casts before you get there. But Ponseti, as it was initially described, was for the early treatment of clubfoot, not for the late children, but it's now being used in even later cases.
So he's also want to know that how to score the children who present late or relapse cases.
So there are a number of classifications. I mean, there's the International Clubfoot Consensus System, the DiMeglio classification. I think you have to read them and go through them. So when you get the late cases, again, I think you have to classify them based on the deformity and the stiffness of the deformity, what treatment they've had before, etc. Okay, so like as I mentioned, the Pirani is not a classification but a score to show you the improvement that you're getting with your casting.
Dr. Pushpinder has asked what the rapid Ponseti technique, rapid Ponseti method of correction.
Yeah, so people are trying to reduce the time that you need to correct a foot by doing the casting quicker. Okay, so instead of waiting as it was originally 6-7 days or 6 days, they're trying to reduce the amount of time to less and less. Now, the problem is if you're casting it, what is the minimum duration that you should have between casting? Okay? Now, we still don't know the exact number. What Ponseti felt, and this is to some extent based on hypothesis, is that whenever you cast or manipulate and cast, there will be some inflammatory response. And to get further correction, this inflammatory response should settle down. Okay, now, whether that's 3 days or 4 days, we don't know. Or whether you really need to at all or not, we don't know. But that is what the Ponseti technique sort of elaborated on. Okay, so now there have been a few reports of good results with this so-called rapid Ponseti technique, or where you reduce the interval between the casts so that you finish your casting within 15 days instead of 4 to 6 weeks.
So actually, Dr. Amagur Sales again asked about modified Pirani score. I think the Pirani score, what we are using is modified one because it contains only hand foot and mid foot. That 4-foot component is missing.
Yeah, that's what I think it's already the modified score that we're talking about.
Yes. So another question is asking about there was a mention about Padma brace from Vellore, that one Padma Pada they called, sir, and one is Dobbs brace. Can you please throw some details and comparison with Steinbach brace?
Okay, so the Dobbs brace has a sort of joint to it. Okay. So some people feel that allows some movement in the foot and maybe better than the Pirani brace. The Padma brace of CMC that you're talking about in Vellore, I've not actually seen or used it myself, so I don't know.
What
In reality, I don't think it really makes too much difference in terms of the functional this thing of the feet.
I think, sir,
In terms of compliance, maybe there's some difference. I don't know.
I think the Cure Clubfoot is giving that Steinbeck brace. I think that is free
Yeah,
of cost.
That's no, the Steinbeck abduction brace is the one that is used in the Ponseti treatment, okay, normally worldwide. It's not the old DB brace that we talked about. Okay, slightly different from the Dennis Brown.
So, Dr. Neeraj Raj want to know if is there any alternative for foot abduction brace after Ponseti method? That I think, yeah.
So
Answered.
the problem is, these are the so you have this kind of Dobbs brace. I think the Dobbs brace also has a detachable attachment to the bar. Okay, so some of them have it with a detachable attachment. Okay, now I think these are so it's like Ponseti described an orthopedic surgeon as one who modifies a procedure the first time he does it. Okay, so these are things which I think eventually everyone will try to make some modification to improve things, but this is work that he put in for 30, 40 years into, and it works. So you don't need to change it unless there's a very strong reason for it. Okay.
So, Dr. Rajan Rai asked why the cast is above knee, why not it is below knee?
So there are two reasons. One is it reduces the chances of the cast slipping. And the second thing is you are externally rotating the foot, okay, in relation to the thigh, and you can't do that with a below knee cast.
Yes. So even in the kites method also, sir, we use the above knee casts, right, sir?
Yeah, but there's no definite reason. I mean, that was mainly to just make sure the cast doesn't slip. In a small child, if it's below knee, it will slip, but in the Ponseti, it's important to get this external rotation and abduction of the forefoot as you do the serial cast, and for that you need something to hold the foot against.
So Dr. Subhanshu is asked about, can we use fiber cast tape instead of POP cast?
Yeah, you can. It's a little more difficult to mold and a little more expensive. So there's no reason why you can't. Some people use soft casts. There are some advantages in that it can be taken off easier by the parents at home. They just peel it off before they come to the casting. Some people, even with the POP casts, ask them to ask the child or the parents to dip the cast in water and peel it off before they come, rather than have the cast cut with the saw and things like that.
So you have mentioned about that the fulcrum is different in that Ponseti, if we compare it with kites. Any other reason, sir, why that kites is not so popular?
So
No.
there were two things. One was the kite method believed in correcting one part of the deformity at a time. So you first corrected the forefoot, then the hind foot, etc. Well, here, when the Ponseti believes that all the elements of the deformity should be corrected, because with the fulcrum at the head of the talus, the entire foot swings round. And as you abduct the forefoot, if you leave the calcaneum free, it can evert. Okay. Now, this is why Ponseti said that so the Ponseti treatment, interestingly, was not accepted for a long time. Okay. He started, like I said, he started it in 1948, and it was really 1990s that this current concepts article came out in the JBJS. Okay. In between, people did not like it. It was actually parents of children who knew other children who got corrected, who started going to Iowa, staying there and getting treatment, that made people take notice of him. And then finally, this article by Dietz and in which they compared the results of the correction of the clubfoot with that of normal people. Okay. Yeah. So that was how you finally got this method popular. And Ponseti famously said about kite is that it took 40 years to get the orthopedic surgeon to move his thumb 1 inch or 1 centimeter, because that distance between the tailor head and the
inequalities. So, Dr. Amay asked, is that it is like calcaneal pedal block moving around the talus?
Yeah, absolutely. It's like what you do in your chest correction also.
Yeah.
And you can combine your chest correction with the principles of Ponseti by, after you distract and you want to rotate the foot, you use the tailor head as the fulcrum to rotate the foot. Yeah, so you can equate it to the same thing.
So as each and everything is, there is that in the Viva, when there is a case of clubfoot, so one term like reverse Ponseti technique, can you just focus some light on that?
So reverse Ponseti technique is really for the congenital vertical talus. Okay. So what you do there is you still do serial casting, but you do it in the opposite direction. So here you're elevating the first metatarsal and abducting the foot. There you're doing the reverse of it. Only thing is you also need to correct, there's also equinus. So the congenital vertical talus has the forefoot in valgus and calcaneum, but the heel is also in equinus. Okay, so you need to bring down the heel as well. Yeah, and then you usually combine it with a sort of minimal surgery and KVAS to hold the position of the foot. So if you look at the congenital vertical talus, here the tailor head is down and the entire navicular has subluxated into the dorsum of the tailor head, which is different to what happens in the clubfoot, where the tailor head goes laterally, okay, and the navicular and all go medially. There, that the talus comes down and this goes dorsally on.
So, Dr. Subhansu is asked that in first cast, that is supination, adduction, inversion, and plantar flexion, how talus head is going in serial cast into normal joint control. I think he's a little confused about that.
So the first cast, all you do is supinate the forefoot to bring it in line with the hindfoot. Okay, because the clubfoot deformity is a supination deformity, but the forefoot is pronated relative to the hindfoot. So you want to bring the forefoot in line with the midfoot and the hindfoot. So you're raising the head of the first metatarsal to supinate the forefoot to get it in line with the hindfoot. After that, this whole block you're abducting tailor head, so that you're gradually abducting the foot on the tailor head, and that is correcting the other elements of the deformity. Okay.
Yes. So,
Jaswinder is
yeah.
busy.
Yes, sir. So, Jaswinder, sir.
I don't think.
Yeah. Yes, sir. Yes, sir. Yes. Okay, sir. So, I think if any other doubt the postgraduate have, then we can take. There is, sir, just one question about that syndromic clubfoot, sir. Do we correct it with, like in arthrogryposis?
Yeah, so you can still correct it with the Ponseti, but they will be much more resistant to treatment. And the likelihood of needing some surgery apart from just sternotomy, goes higher. Okay. And the risk of recurrence is higher. You may have to add surgery to your treatment. Okay, but these feet are stiff anyway. Okay. You're not adding to the stiffness by doing surgery. The normal club foot, the normal idiopathic club foot, the foot tends to be supple, but by operating, sometimes you end up with a stiff foot. Okay.
Yes. So one more question: where are details of chest surgery given? Any specific book?
So
I think
actually, Dr. B.B. Joshi came out with a book when he first came out with the chest fixator. Okay. That gives a very detailed thing about it. He also had a, so I don't know who has it now. There's also, I think, I'm sure it's been written up by Dr. Lord and Sudhir Warrior, etc., when they described the UMEX fixator, which was really based on the chest fixator.
There is one book of Jess in general, sir,
Yeah.
by Dr. Joshi only.
That B.B. Joshi's book I know about, that was right in the beginning he came out with the book, which has all about, in fact, it has just in other parts, I mean, the fixator in other
Yes.
parts also, like hands.
and so just one last question, sir. According to the age, do you describe like Ponseti technique? We do it for every week, usually 5 to 7 days. So if it is the child is larger or the
If it's
bigger one,
older child, you can increase the interval between casts.
yes, sir.
Okay, so 10
Okay,
days
sir.
or even 2 weeks sometimes.
It is okay. Okay, sir. Jaswinder, sir.
No,
Please.
I joined very late, so I'm not very sure what all was discussed. I'm sorry for that. Sir, atypical club foot was that discussed?
You
I
just
deliberately stayed away from that because
Okay, sir. Right.
to understand the Ponseti technique rather than other things.
yeah.
So,
There was one patient which I had discussed with sir also. He was a quite a chubby patient, and every time I used to put a cast for him, he used to come back in 2 days and take out the cast by himself by hitting on the floor or something on the bed. So for that one modification I did was like maybe many people are doing it. So I used tincture benzoin. That is what sir suggested me. And in spite of the regular cotton, the synthetic cotton which I usually use, in that patient I use a normal regular cotton, not a synthetic one. So it kind of slipped less. And third, as again suggested by most of the surgeons, is I had to do an early tenotomy because the foot one was in so much plantar flexion that it was like almost a straight foot. So it used to just slip out. So an early tenotomy and then correcting rest of the deformities, whatever was left. So I
yeah,
did
so
get it.
there are some people who do that where there's a severe equinus, but you may have to repeat the tenotomy at the end sometimes. The other thing is what we call the rocker bottom foot. So if you are trying to correct the equinus before you've corrected the other elements of the deformity, or you try to force equinus, then you will get a midfoot break. Okay, so then you get like a rocker bottom, which is a bit like a vertical talus in terms of the deformity, and there you have to actually again to some extent reverse the casting process of Ponseti and then go back to gradually correcting it again. So we've had one or two like that where they've had a very severe rocker bottom foot and then we've had to reduce deformity and then go on to the regular casting and then do a tenotomy at the end. So those are described as complex. Those are the ones that you have to do an X-ray. Like in the regular Ponseti treatment or for the idiopathic club foot, an X-ray is not part of the initial investigation. Some people do an ultrasound to look at because it's mostly cartilaginous, a lot of cartilage at that stage, but that's more for research purposes than any actual real advantage you get in the treatment.
So when would you like to get a X-ray done for a CTEV as such?
So if they've recurred after treatment or they come with post-treatment with a rocker bottom deformity, then I would definitely get it.
But regularly never, sir. I mean, the
I've
first fresh
stopped
case.
doing it. Constantly doesn't, yeah. When they come without any other syndromic this thing or any other features to suggest some skeletal dysplasia or something like that, I would not routinely X-ray them. If anything, I would get an ultrasound and not X-rays.
Right.
Okay, I think we should call it a day. It's already 8 o'clock.
Yeah, thank you, sir. It was quite informative.
Bye.
Yes. Thank you so
Thank
much.
you. Thank you.